Okay. So, hi, Cindy. It's good to talk to you. Thanks
Good
for
to see you.
doing this. So, I wanted to ask you specifically, you've recently been involved in starting like a medical education resource center. So I wonder if you could tell me about that and explain what exactly it covers and what you think, why you think this is the time to be doing this, what the need is.
Well, we have been focusing on medical education at BHC for a while because along with research regarding MECFS, provider education is just hugely important. It's still one of the most important things that patients can't access good care because they just can't find clinicians who have confidence making a diagnosis and treating the illness. So this has been part of our mission at BHC. And it was really fortunate during the pandemic that when research shut down and we had to close the clinic for a while, we could still work feverishly on our medical education resources online. And that really gave us a leg up and got us even more enthusiastic about it.
Mm-hmm.
And more recently, we have partnered with Open Medicine Foundation because they have a vision and a great reach. And we have a lot of materials already, but what we hope to do is combine their skills and our skills to push the agenda of provider education even further. And that really needs to focus on physicians initially, but we really hope to target all kinds of medical and mental health providers with knowledge about MECFS.
So in medical education, I mean, I guess one would think of it sort of, or might think of it as just medical school, but it's really a broader construct than that, isn't it? There, with continuing medical education and so on. What are the different kind of venues, medical that you see this working in, or that you see kind of going into?
Yeah, it's really important. So the major ways doctors get educated in the US, first of all, in medical school, then in residency and fellowship training. So those are the majority of influence comes from the academic institution where they are and what that the views of that medical institution. Once you get in practice, then there's kind of a hodgepodge of ways that that physicians stay up to date, and that might include continuing medical education, but that even comes from many sources. That can come from the institutions where they work. It can come from medical societies, and it's a little bit disorganized, but physicians, there is really not a good universal plan in this country for training medical students and residents about any post-viral syndrome, but especially not MECFS. And that has persisted.
So let me see if I can clarify. It sounds like there are sort of three general areas: one medical or venues, one medical school, one the training into whatever specialty or internship or whatever at the particular institution where they're doing, if it's UCSF or if it's Johns Hopkins or wherever they're doing their internships or fellowships and residencies, and then when they're actually in practice, whatever varieties of ways they're getting their information later, and that might also including the ones you said. Online sites like UpToDate and other kind of professional websites that provide clinical information.
Right, and continuing medical education as well. So yes, there are these highly respected sources. The good thing and the bad thing about medical education is it requires a very strong evidence base. That means there have to be very large studies, replicated studies, and everybody has to agree essentially on something before it can be included in medical education, and that includes continuing medical education. So it's really hard for new ideas or advancing science to make it into education for 10 years. It takes a long time to get trickled down from science into medical education. And of course, but COVID, and particularly long COVID, has totally just blasted this philosophy out of the water, right? And including, and another arm of that is what gets published in the first place. So we've been a lot looser, and the whole system has had to loosen up and be more flexible to get information about COVID out there very rapidly. So publications have happened quicker. There have been all these sources of pre-publication publications that are available online.
Right.
And, we want to follow on the tail of that, right, with long COVID, so that it doesn't take 5 or 10 years for information about long COVID to be taught to physicians in training.
So let me back up for a minute. When you were in medical school, what did you hear about? No one called it MECFS then. Probably you heard, if you heard anything, it was about chronic fatigue syndrome. And did you hear anything at all about that?
No, but that's because my career spans the awareness of these illnesses. So what the beauty of Johns Hopkins was, it taught me how to be a critical thinker and encouraged us to think outside the box, because Hopkins is a leader. And they said, you can't just implement the status quo. You need to be the ones who push that envelope and ask the hard questions. And that isn't true everywhere. But I came out of my medical school and started my residency in 1987. And the first case definition for chronic fatigue was published in 1988, the first year of my residency. And the first criteria for fibromyalgia were in 1990, which was toward the end of my residency. And then the revised criteria for MECFS, the FACUDA, that were unfortunately ill-fated and really were too broad, were in 1994, my first few years in practice. So I really had to learn everything on my own after medical training.
Okay. And it was something that you really learned more through probably client practice, maybe one would say, rather than through continuing medical education or other ways in which one might normally get post internship or post-residency training. Would that be correct?
Right. I mean, I learned about it by searching the published literature, because that's when the first published literature was coming out. And also it's when the very first scientific conferences for chronic fatigue syndrome were starting up. And, I was able to, because I was interested right when I began my medical career, I went to these early conferences on my own dime, because I was interested, and sat with Paul Cheney and Nancy Klimas and other people who were early in the field, and really learned right away from people who were trying to do the science. And it was transformative, right? And there was nothing, there were no CME, there was nothing like that.
And so what is the specific goals? Now you're part of this partnership with OMF. And so what specifically are you doing in terms of addressing what you see as this gap in what's available to both clinicians in training and actual clinicians once they're clinicians?
Right. Well, there are many ways to go about changing views and helping people get educated. And we have tried to just take advantage of every opportunity that came up. If someone wants you to give a lecture, if they want you to do a CME program, you say yes, right? So I've tried to say yes and just get it out there, create a product, and then put our product online. But really, that's a slow way to do things, one by one. And I've been teaching nurse practitioners at the University of Utah and teaching lectures in the PA class and giving the occasional lecture to residents. But what has to be done is starting from the major resources that are providing information. And they're the hardest places to convince to revise and put their leading information in, especially if there's not a large evidence base yet.
Is it you're talking about, for example, UpToDate, that kind of first?
So exactly, like UpToDate and Medscape and the Hippocrates that serves as a medical resources. Many of these pop into people's electronic health records. They type in a diagnosis, and also getting reform about the ICD.
You're breaking up there for a second.
Codes and teach those
things
perpetuate false thinking.
You
are too. I don't know if I turned everything off.
Now it says my connection is unstable. Are you there? Can you hear me?
It's possibly on. Yeah, I'm here. It's possibly on your end.
Everything seems turned off. I don't know what else it would be, but I am technologically inept. But I can hear you. I mean, if what you just said, I can hear. So I think let's try to continue, and hopefully people can make the best. You were repeating what you said? I think you said something about ICD codes. Did you say something about that?
Yeah, so this is just the attempt of all of the advocacy community, those of us who are professionals and patients, to find ways to educate. And one was this has been a long process to reform ICD-10 codes. Those are diagnostic billing codes.
Right.
And we now, as of the beginning of October, actually have a code for myalgic encephalomyelitis chronic fatigue syndrome
Right.
that didn't exist. And we have a new code for POTS. There was no code for postural orthostatic tachycardia syndrome. So it's gradually going into these large electronic health records so these diseases can be tracked. And once the diseases are tracked and recognized, then people feel the need to learn about them.
And so again, what specifically is the education and medical education center doing specifically? Are you developing currently CME modules, or what is the activity of the project?
So there are many activities, and we're trying to explore different ones every day, trying to figure out how to branch out and to tap into additional educational resources. One of the first things we did was a case-based online learning program called ECHO. And this is a way of taking a specialist, reaching out to providers out in the field who come online and talk about cases, learn a little bit about a disease, bring their cases, talk about their hard questions. How do you manage this? How do you manage that? And we have had a 1-year long program where we meet every other week and invite clinicians throughout the system of the University of Utah. You can actually join from anywhere where you have internet access. And what we've done is designed a program to talk about long COVID and post-viral syndromes, as well as ME/CFS.
Okay. And so any other things you want to talk about that you've done or that you're planning?
We are hoping to, I think our plans are just coming together.
Okay.
But we really need to, the thing I'm happiest about actually is all of us have been working on the federal institutions for a long time, and our federal institutions really get ME/CFS now. Now, maybe not institution-wide, but we have very well-educated people at the NIH and the CDC and the FDA who are open and trying to have a much better source of information regarding these illnesses. Other resources might include state medical societies, where they send out newsletters to their doctors. Major professional associations like the American Medical Association or the American Association of Family Practice. We can maybe reach out to those, make sure that their resources and what goes out by way of education is up to speed.
Now, about like the Cleveland Clinic and Mayo Clinic. I know I've heard there's been some shifting at Mayo recently, but they've sort of really been repositories of problematic old line thinking on some of these things.
Right, and they're kind of insular, very well-established institutions that don't understandably want to be told what to do, right? But what we've tried to do is cultivate somebody within that institution who can then make a difference within their institution. And that's happening now at the Mayo Clinic. Stephanie Grach came and spent a month at Bateman Home Center working side by side with seeing patients in her last year of internal medicine residency. And she came very well prepared to begin with, and went back really incentivized to bring new information on COVID and comorbid conditions.
And again,
we have people.
You broke up a little there. This is who?
Her name is Stephanie Grach, and
with Mayo.
She was a Mayo internal medicine resident and asked if she could come to the Bateman Home Center her last month of residency before she became faculty.
Okay.
So yeah, so that's another thing we've tried to do is provide a place for interested clinicians in training to come work side by side with us and meet patients and learn from patients, because there's no doubt once you actually meet a patient and learn about their lives, the doubt all goes, right? Because that's the problem. And then, we have now these funded, the people who were funded by the NIH in the last cycle, where there are scientists at each one of those places. So at Columbia and Cornell, and they're also at Jackson Labs. And then we have OMF funded the Stanford Center. So we have really respected institutions with insiders now. We just need to line them up with clinicians, particularly clinicians who are seeing long COVID, and help connect the dots for them.
Are you still seeing, I mean, are you seeing a lot of misunderstanding among clinicians about long COVID, which obviously is a term that covers a lot of ground, but let's say specifically the people with long COVID who have the cluster of symptoms that look like ME in terms of the non-specific symptoms, the brain fog and the relapses and so on. What's your sense of how clinicians are coping with that, or seeing that there still seems to be a lot of thinking of it being either psychogenic or driven by anxiety and depression and so on?
Well, there are some really well-equipped places that are trying to tackle post-COVID conditions. And a lot of them are places that were hit hard by COVID. And the exact opposite of what's happened with MECFS, it's really the best in these really high-level institutions, Mount Sinai and Stanford, and places where they have particularly good physical medicine and rehab facilities. And some of it's called PM and R. And I've heard some amazing insights from those people trying to help people rehab from COVID, and discovering that they can't really rehab them the same way they would a person who has another illness. And it's helping them become introduced to post-exertional malaise, right? To impaired function and post-exertional malaise and MECFS. And so I think we're going to get, all of our institutions will be forced to deal with this, because we have so many people who haven't recovered from COVID. And it will go from academics and spill down.
There was an acronym that you used that I didn't quite hear just then.
PM and R. It's physical medicine and rehabilitation.
Oh, okay. Okay. Okay.
It's a rehab doctor.
Okay. So do you think there's been a lot of debate, obviously in the MECFS community, about whether long COVID is, good or bad for MECFS, or is it the same thing, or how do they relate? Will, long COVID waves swamp attention to MECFS and all that? Then there's obviously others who feel like, well, you have the symptoms of MECFS, you have the same thing. Many people are getting diagnosed. The mechanisms look very similar. And this will actually help MECFS patients. This brings attention to MECFS. Where do you sort of come down in that conversation?
Well, it's complex, because there are lots of ways to be helped. MECFS patients aren't getting any more help, but neither are long COVID patients. I mean, we're not, for the most part, long COVID patients aren't getting much help. No one's getting much help. But so along the line, is this materializing into help right now for patients getting care? No. But it is going to help. There are reasons why it will help in the long run. And that is, it's going to bring many, many more providers into the field, because that will happen naturally, because there are so many long COVID patients.
And the field being treating
the field being all post-viral conditions, right? People who aren't getting better after infections, and they have post-exertional malaise, and they have some related comorbidity. And it's not just post-viral, it's post-infectious illness, like post-treatment Lyme disease. And the whole, dysautonomias and mast cell activation. And all of these poorly understood disorders have been marginalized, but now that more and more clinicians and scientists are asking the same questions we've asked for 30 years. But they're
I'm gonna move to another part of my house. It might be better. I might better get
it will.
just move to another part of my house and see, I might better get a connection here. Are you there?
Okay. Sorry, I was talking and talking.
So that was, yes, I think it was probably part, yes, I see I was in the wrong part of my house, but I have a better connection here now for some reason. I'm below Twin Peaks, which sort of blocks at different times, can block the reception at different times. Well, so why don't you just repeat the last thing you said? And I think we're probably close to wrapping up.
I can't even remember what I said, except to say that, well, on the face, it doesn't appear that long COVID's helping MECFS.
Right.
It will help. It will just be slow. Because first of all, we're going to have more and more medical providers who are savvy about these presentations and more open. And we're going to have more and more science about immunology and virology, and the interest is there. The machine just moves slowly. So
do you think part of it is a sort of a replacement thing, that it's very hard to get clinicians who've been in the field for 20 or 30 or 40 years to sort of change their minds about what they viewed as chronic fatigue syndrome, and now what maybe they view as the people who are suffering from, chronic non-specific symptoms after long COVID? Is part of this going to be just younger clinicians coming up and seeing what's happened?
That will play a role, because that always plays a role, right? There's always the old guard that carries the wisdom but has a hard time adjusting to new ways. We have new technology, we have all kinds of things that are going to make faster progress, but that's relative. But I have absolutely no doubt that we will learn more about, by studying post-COVID conditions and COVID, that will help MECFS and all the related comorbidities. I have no doubt that it will move things forward. It's just going to be painful and slow, because it's always painful and slow,
right?
Especially treatments.
Okay. Listen, thanks very much. I really appreciate it.